few minutes ahead, but we got started late because of the opening ceremony. So I'm going to bring the next speaker up now, and that's Dr. Pramod Medical.
So for this lecture, just a little background. For the purposes of this lecture, we're going to talk a little bit about where we are right now at late 2015, a little bit about where I think we're doesn't work. Here's just a few studies. These are only the recent studies. I'm not even showing you studies going back 10 years. Now, this takes us to a concept that was introduced probably about 15 years ago by Mickey Eisenberg, phases of resuscitation. The first 5 minutes or so are known as the electrical phase. That's when the cardiac arrest is the circulatory phase, and it's that period of time it actually work. And then beyond 15 minutes, we get into the metabolic phase. And what the studies all consistently, based on a couple of the articles that have been recently written, is that if during the first 10 to 12 minutes or so, once you're in the metabolic phase, the benefit of cooling is simply that it prevents fevers. And fevers are terrible for the patient. Here's a nice study that talked about the morbidity and mortality associated with the fever. Post-cardiac arrest patients, that bear in mind that they haven't come out and said therapeutic hyperthermia doesn't work. What they're cooling to either 33 or 36, and they say for 24 hours. It used to be 12 to 24. And somebody's pulse is back. You get a 12 lead EKG. There's your EKG. They have a STEMI. How many of you are not activating your cath lab? How many of you refuse to raise your hand for any question? But the wealth of data really says that patients with a non-STEMI, what if they have a non-ST elevation ACS? STEMI. Here's an article from Journal of the American College of Cardiology by Yui. The most influential factors, perhaps all patients that are post-arrest, primary cardiac arrest, are going to benefit by going to the cath lab. And a big reason for this is that the post-cardiac arrest EKG is not a good indicator of whether they have a transmural MI or an infarct-related artery. But in the post-arrest patient, the EKG is a reason to not take them. And so with that in mind, in 2004 about this, but they shot themselves in the foot by publishing this. So just several months ago, the Interventional Council of the American College of Cardiology came out and put all the literature back. What if the patient has a non-ST elevation ECG? What do they tell you to do? Well, what they tell you to do is consult cardiology. Pick up what are those adverse unfavorable resuscitation features listed up here. This is going to be of surviving the cath. So if the patient has multiple of these features with the non-STEMI, don't do the cath. Seems sensible. But non-STEMI, their own interventional council says, do the cath. Again, right out of their own guidelines. So take this algorithm. We've adopted this algorithm, by the way.
And especially over the last year, I would probably call it a practice changing in sepsis, because there were so many studies which came in the same field, and all of them pointed there is a change in practice which is happening because of the new studies which are coming. The first study in pediatric emergency is randomized controlled trial of single-dose oral dexamethasone versus multi-dose prednisolone for acute exacerbation of bronchial asthma in children who attended the emergency department. This is still in press, so it is to be published in the Annals of Emergency Medicine.
Not now when I'm an old man. I would far rather have known this at the beginning rather than at the end. And really what I'm going to consider today is the barriers to publishing. Then to have a think about how we can beat some of those barriers and try and get a paper that will get us into the kind of literature review that we've heard so well today, in terms of information that changes practice.
The emphasis on antiarrhythmics. I don't use antiarrhythmics, right? Some people do because they simply have a desire to do something, but the data says that antiarrhythmics don't work. Post-arrest care, immediate PCI for STEMI as the default. If it's a non-STEMI, strong consideration, and we discussed all those cases with cardiology for primary cardiac arrest. Therapeutic hypothermia, we're cooling everyone, right? 33 or 36, it doesn't matter. Somewhere in there. Somewhere in there. And definitely avoid hyperoxia. And then future questions, what's the role for epi? We kind of alluded to this question already. Therapeutic hypothermia, what's the role there? There doesn't appear to be a rush, but is there some optimal temperature? Not sure yet. I didn't talk about extracorporeal life support because there's no randomized studies. This is one of those maybes in the article. They say extracorporeal life support is a hot topic. It may be helpful, but no good data yet. Same thing for devices. Further data.
My name is Adrian Hugnadi. I'm working for Stryker Corporation. I am Business Unit Director Medical, and today here we are launching a new product and we are presenting the product to emergency conference for a Powerload, which is our latest and the greatest ambulance cot that can bring the patient into the ambulance with the touch of the button. So I can show you how does it work. This is Stryker ambulance cot. It's called Powerload. So it's the powered hydraulic battery operated cot, which helps paramedics to load and unload the cot with the patient into the ambulance with a touch of the button. I will show you how does it work. So everything goes with the touch of the button. So we are going to pick up the patient. I'm not holding and lifting anything, I'm just pressing a button here. We are picking up the patient and we are loading the cot into the ambulance. The capacity of this system is 400 kilograms, so it can carry bariatric patient and neonatal, so the incubator transport as well. And it will, you see that I'm not lifting anything, and it will lock automatically, and the battery system will be charged wirelessly. And this is how does it work.
My name is Lindsay Foxcroft. I'm the Managing Director of Trauma FX, and I'm here in collaboration with Leader Healthcare to provide simulation and moulage for military emergency and trauma training. We're here to demonstrate a range of simulation products to create realistic injuries for training, and we have some wound effects that we're going to be demonstrating, how to apply them, how to use them during training, how to make simulation more realistic for different training purposes.
Our aim is to make simulation and moulage in training more realistic. So for this we have a range of products. These are a specialist sim wound. Anybody can use them. They can be applied to the skin or onto a mannequin, and this will simulate a realistic injury. We also have sim wounds and sim sleeves. This is a sleeve that can go onto a limb to simulate the injury realistically, and it enables training nurses and doctors to simulate treatment in a scenario-based assessment. We also have blood products that are simulated bloods, like what is on here. realistic bloods that can even go on the face and in the mouth, simulating bleeding around the mouth area. So these kits enable training centres and education to be more realistic by providing moulage on both standardised patients and mannequins.
My name is Ahmed Al-Ahdab. I am the managing partner of Pramod Medical company. It's a trading company specialized in medical supplies. We serve the country United Arab Emirates as well as some other GCC countries since 1998. We are focusing on emergency and rescue items, and now we are participating in ESEM show for the second time, placed in Abu Dhabi here. We have different group of items. Let me start with the first one, which we call it INCAS. INCAS is an idea of having different kind of rescue and ambulance items kept in a big cupboard, which it's really could serve to save life in the location of accident. Maybe we can just take some shootings about the products now and to show the details of that one. Also, we serve the military field hospital by providing different kind of emergency evacuation and field items. We serve Red Crescent, we serve National Ambulance, we serve Dubai Ambulance with different kind of emergency bags and first aid items. One of our unique items, we call it antimicrobial uniforms. We tried to launch it in the market, which is a garment made of special fabrics, and it's antimicrobial, so microbes will not be transferred from room to room and from ward to ward, whether by doctors, physicians, nurses, or the patients themselves. It's really very unique items. I would like to pass the mic to Engineer Arya. She's the one responsible for technical issues with Pramod.
Good morning, I'm Arya. Okay, now I will introduce about our products. This is the uniform. It's from the US company. Its name is Morlau. The main specialty of this one is it will not penetrate any liquid or any microbes to inside the body. Okay, so and it is treated with Teflon and Silipure also. So this one is more comfortable for the doctors and nurses, and mostly the main property of this one is the antimicrobial.
This is one of our unique products. We call it as NCAS. It means rescue in Arabic. Okay. In this we have different types of products. We arranged it in the order of different types of emergencies like general, cardiac and respiratory problems, burns and trauma also. In this we have trauma kit, and for the burn items also, for the cardiac arrest, if there is any emergency occur in office or malls, any parks, everywhere, we can use this one. It's like a cupboard. In this we have different type of stretchers, the spine boards, everything, and the Boston spleens for the fractures. This is the defibrillator for the cardiac problems, and this is for the trauma kits. In this we have one alarm system for alert the people about the emergency. Whenever we open the system, the cupboard, it will put alarms, and all people will alert about the emergency.
Hello, I'm Jim Harmon from the United States. My current professional positions are President of the International Federation for Emergency Medicine and Professor of Military and Emergency Medicine at the Uniformed Services University in Bethesda, Maryland, and Professor of Emergency Medicine and Public Health Sciences at Penn State University in Hershey, Pennsylvania. And I'm one of the invited speakers here at the Emirates Society of Emergency Medicine Annual Scientific Conference. The topics I'll be speaking on tomorrow include a summary of all of the different activities that the International Federation is currently doing with encouragement of members of the Emirates Society of Emergency Medicine to participate in the various different activities that the International Federation is conducting and join the committees, task forces, and special interest groups. Then I'll also be speaking on humanitarian disasters and presenting an analysis of our current responses to these tragic events. Then on the following day, I'll be presenting a plenary session on the critical role of the specialty of emergency medicine in public health. And I'm looking forward very much to making these presentations and hopefully having some discussion and questions and answers from the audience.
My name is Dr. Nadim Qureshi. I'm a professor of pediatric emergency medicine at St. Louis University in US, and I'm currently serving as the scientific chair for your Emirati Society of Emergency Medicine program over here at this annual conference. So under my responsibilities, I have been able to develop this program. We have over about 100 speakers in this program, 700 attendees. The program is enriched with some really extraordinary new presentations which have never been presented before over here, some new kinds of workshops, different tracks, and we are hoping that the mark which we set in 2014, we will pass that mark. I think overall so far the attendance has been very good. People have been very happy. We've had some great lectures since morning, and we are aiming to see the next 2 days to be a very successful conference.
My name is Gary Gattis, and I'm an MD PhD. I'm a professor of emergency medicine from the University of Missouri, Kansas City, and St. Luke's Hospital in Kansas City, Missouri. And that's in the very middle of the United States. It's been a real honor and privilege to come to this Emirates Society for Emergency Medicine meeting and present a pre-Congress workshop on starting research in a low-resource environment, and also to present an update on the literature and emergency medicine related topics that appeared in the literature for stroke and cardiovascular diseases during the past year. This is a really high-class conference. It shows what a conference can grow to quickly when it's given lots of good resources, and it has lots of very attentive, capable people to plan the Congress. This Congress is probably one of the best planned and best executed of any at which I've ever attended or spoken. And it speaks to the level of attention and level of detail that's taken on by the conference organizers. They present a first-rate conference with first-rate information, and they make it very easy so that all I have to do is prepare and show up, and I know that I'll have a good audience and I'll have a very good conference venue. I hope to be invited back next year.
Hi, I'm Dr. Gregory Stoll. I'm an associate professor of emergency medicine at Harvard Medical School. I'm here speaking at the Emirates Society of Emergency Medicine 2015 Scientific Assembly. I've had a very enjoyable time. I've had an opportunity to do a workshop on hospital-based emergency preparedness, had an opportunity to chair a disaster medicine track, and then finally doing a keynote presentation in disaster medicine on last year's Ebola outbreak. I've enjoyed the Emirates Society of Emergency Medicine conference very much. We also debuted our new disaster medicine textbook named Ceatone's Disaster Medicine, 2nd edition, of which Dr. Salafaris is an associate editor on. So we had the opportunity to talk about the textbook a bit and do a book signing here at ESEM. So it's been a great time, and I look forward to ESEM 2016.